Good afternoon, everybody, and welcome to the 7th webinar of the 2021 year in the ACCP Immunology and Transplantation PRN webinar series. My name is Nicole Pilch. I'm the Director of System Quality at the Medical University of South Carolina, and it's my pleasure to moderate today. Today's webinar is titled the ATC Recap Webinar, and we are honored to have Amanda Szczepanik and Stephanie Heeney present today. Amanda Szczepanik is a solid organ transplant pharmacist at the University of Maryland Medical Center in Baltimore, where she rotates inpatient coverage through kidney, pancreas, liver, heart, lung, transplant medicine, and transitions of care clinic. And in addition, her responsibilities at UMMC is the co-chair of the AST Transplant Pharmacy COP, and she's completed a PGY-1 residency at the University of Cincinnati Medical Center and a PGY-2 solid organ transplant residency at Duke University in Durham, North Carolina. And she completed her pharmacy school at MCPHS University in Boston. Stephanie Heeney received her Doctor of Pharmacy from the University of Washington in Seattle, and she went on to complete a PGY-1 and PGY-2 in solid organ transplant at the University of North Carolina Medical Center, and is currently one of 3 cardiothoracic transplant pharmacists at Vanderbilt University Medical Center. And in a moment, I'll turn it over to Amanda to begin the presentation, but first there's a few quick notes I want you to hear about. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We'll take a look at the question at the completion of the presentation and make sure we get it answered. And there will be an evaluation for this webinar available at its conclusion, and we encourage you to complete this to let us know how we did and how we can improve the webinars going forward. The slides from today's presentation will be posted on the ACCP website in the section titled Webinar Slides after the presentation. And if you experience any technical difficulties during the webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware through the chat functionality. And there's also a live chat on the upper right-hand corner of your screen where you can get live technical support from any meeting whenever you need it. And now, without further ado, I'll turn it over to Amanda.
Thank you, Nicole, for that introduction, and thank you to the PRN for the opportunity to participate in this presentation. I'm going to kick off by starting our discussion about the abdominal abstracts that were at ATC this year, and we will start off with kidney. The first abstract I'm going to present was looking at an evaluation of a weight-based mycophenolate dosing protocol for kidney transplant immunosuppression. The purpose was to look at safety and efficacy outcomes of a weight-based dosing regimen in kidney transplant patients in the single-center retrospective study. It was a 1-year outcome evaluation looking at before and after implementation of this weight-based dosing protocol. Transplant recipients had standard triple immunosuppression with a TACRO goal of 8 to 12, prednisone taper to 5 milligrams daily by post-op day 5, and then one arm, referred to as the fixed dose arm, received the standard MMF 1,000 milligrams twice a day, and the second arm was the weight-based arm, where patients received reduced doses of mycophenolate based on their weight. You can see on the slide, patients who weighed less than 50 kilograms received 500 milligrams of MMF twice a day, and those that were between 50 to 79 kilograms received 750. Patients that were excluded from this study included those receiving basiliximab induction, a prior history of transplantation, multi-organ transplant, African American recipients, and those that experienced delayed or slow graft function post-transplant. 140 kidney transplant recipients were included in this study. There were 70 patients in each arm. You can see the general layout of the percentage of patients in each weight-based group. However, I would like to highlight the fact that there was a larger number of patients who weighed more than 80 kilograms in the weight-based, as well as the larger percentage of patients who weighed between 50 to 79 kilos in the weight-based. When looking at primary outcomes, including biopsy-proven acute rejection, and secondary outcomes, including infection and hospitalization, we'll focus on the graph on the left to start. Purple is the fixed dose, pink is weight-based, and what you can see is between both arms, there were no significant differences in biopsy-proven acute rejection, infection, or hospitalization between either arm. However, when the researchers pulled out a subpopulation looking at patients that weighed less than 80 kilograms, the researchers again didn't see any significant trends in these outcomes. However, there was a higher number of patients in the weight-based arm that developed rejection within the 1 year after transplant compared to the fixed dose. So 19% of patients in the weight-based developed rejection compared to 9% in the fixed dose. No difference was seen in the incidences of infection, and then there was no significant difference in incidences of hospitalization, but the researchers did focus a little bit more in on what different causes of hospitalization there were. So looking at infection as a cause of hospitalization and neutropenia, there were no differences between the two arms. However, when looking at the graph in the middle here, you can see that the fixed dose MMF, which is the full 1,000 milligrams, had higher number of readmitted patients due to non-infectious GI side effects. 13% of patients in the fixed dose arm compared to only 3% of patients in the weight-based arm were readmitted for these reasons. Looking at myelotoxicity, which included leukopenia, neutropenia, severe neutropenia, and granulocyte colony stimulating factor, there was no difference between the two study groups. The researchers concluded that weight-based mycophenolate dosing resulted in similar rates of rejection, infection, and hospitalization in standard immunologic risk kidney transplant recipients. However, it was associated with fewer hospitalizations due to new non-infectious GI adverse events. One point that I think is important to mention is during the rapid fire oral presentation, the researchers did state that the mean dose of mycophenolate was similar between all groups, regardless of their weight or protocol at the end of 1 year. What this means is that likely in the weight-based arm, several patients had their mycophenolate dose increase throughout the study period, so this can bias the results slightly. However, the researchers did state that this study or this abstract supports weight-based lower dose for patients with lower total body weight. So this would be utilizing either 750 milligrams or 500 milligrams based on according body weight. The second abstract to present is looking at the use of single-dose basiliximab induction therapy in a low immunologic risk population, focusing on graft outcomes as well as infection outcomes. This was a retrospective single-center observational chart review looking at kidney transplant patients aged 19 and up from June 2019 to May 2020. The maintenance immunosuppression can be found on the left-hand side, TAC goal 8 to 12, MMF 1,000 twice a day, and prednisone titrated to 5 milligrams over 6 weeks. The researchers identified a low immunologic risk population based on a point system. So if a patient had 0 points, they would receive only single dose basiliximab, but if they had 1 to 2 points, they would receive standard dose. The criteria that attribute points are listed on that slide and includes retransplant, African American recipients, 6 antigen mismatch, lupus, DCD, and then a higher point is attributed to PRA greater than 20% and ABO incompatibility. So it does highlight a low immunologic risk population looking at this. Focusing in on just the single dose basiliximab arm, there was no comparison in outcomes between single and standard dose. 57 patients received single dose basiliximab, and of this population of 57, 20% were below the age of 40 and 54% were above the age of 60. 70% were male, and the average PRA was 0%. 2 patients out of this cohort developed acute cellular rejection, and 1 occurred at post-op day 5 and the other occurred at post-op day 20. And what the researchers found looking at these 2 patients is that both had subtherapeutic TACR levels at and around the time of the rejection episode. 1 patient developed antibody-mediated rejection, and then looking at graft survival, patient survival, pretty standard compared to expected outcomes. BK viremia was 22.8% and 25% of patients had CMV viremia. What the researchers concluded was that single-dose basiliximab in low immunologic risk patients does appear to be safe and effective with low rates of biopsy-proven rejection and graft loss. However, it is important to note that when patients have subtherapeutic TAC levels, they had higher rates of rejection. So it's important to maintain and optimize maintenance immunosuppression early on. We're going to transition into two belatacept abstracts. The first is a PK analysis comparing the BEST and BENEFIT trials. The purpose of this study was to assess Bela exposure post-transplant and compare pharmacokinetic parameters from the low-intensity BEST samples to previously reported BENEFIT reports, looking at how it translates into rejection and infection data. Bela concentrations were analyzed using the same assay used in the phase 1 through 3 studies, and clearance was estimated using a published Bayesian approach, and allometric scaling was incorporated, which is clearance standardized for weight. Starting off, looking at belatacept trough concentrations on the y-axis and time post-transplant on the x-axis, red line denotes the target threshold concentration used to guide the low-intensity dosing regimen, and open white boxes represent BEST data, and the black closed boxes represent the BENEFIT data. What the researchers saw was that at all time points post-transplant in both the BEST and the BENEFIT trial, Bela concentrations were at higher levels, higher troughs than the threshold at each time point. When looking at how pharmacokinetics played a role based on patient demographics, the researchers investigated differences in concentration average and area under the curve based on several different demographics. Both concentration average and area under the curve trends showed similar results to what I have on the slide here. So both concentration average and area under the curve, what the researchers saw was a significantly higher exposure of Bela in male patients during 6 to 12 and 12 to 18 months post-transplant. They also saw higher Bela exposure in patients with a BMI greater than 30 at all time points post-transplant. On the flip side, lower concentrations were seen in patients under the age of 60 and those African American at all time points post-transplant. The researchers also investigated how Bela trough concentrations and pharmacokinetics played a role into rejection, and what they saw was that concentration average and area under the curve with rejection, patients with rejection, was not statistically different at any time point compared to those without rejection, except for the 6 to 12 month time frame. So between 6 to 12 months, there was slightly lower concentration average and area under the curve in those patients with rejection. However, it is worth noting that the majority of rejection episodes were seen prior to this 6 months. About 63% of patients rejected prior to 6 months, and 26% of patients rejected in the 6 to 12 month time frame. Bela exposure was not different in patients overall rejecting versus not, and there was no difference in the allometrically standardized clearance in patients with rejection, whether it's an initial or recurrent episode, compared to those without. When moving on to infection outcomes, there were two abstracts. So one was focused on rejection and the second one was focused on infection. The chart on the left-hand side is denoting Bela concentrations at 6 and 12 months post-transplant. And what the researchers found was that there was higher area under the curve in the average concentrations in patients who developed infection, including viral, compared to those without. When looking specifically at BK, the researchers found that patients with BK experienced a 12 to 15% increase in their area under the curve within the first year post-transplant. There was no significant difference in bacterial or fungal infected patients, and no difference in exposure of Bela with CMV. However, this may have been prevented through Pjp prophylaxis. So that's just one thing to keep in mind. What the researchers of this study concluded was that patients under the age of 60 and African American have differences in clearance compared to other patients at all time points, and that based on the infection profile, reducing Bela exposure during the induction phase by reducing milligram per kilogram doses or different body weights may be warranted. Again, Bela concentrations at lower doses may translate to a more improved profile related to viral BK and overall infection. And some future studies the researchers posed would include alternative dosing strategies. So this could be reducing the induction dosing for belatacept or changing the time frame at which doses are administered, therapeutic drug monitoring, so looking at Bela trough levels, as well as further identifying or investigating trends between Bela concentrations and infections. The second Bela study I'm going to review was looking at the impact of obesity on acute rejection and graft function in kidney transplant recipients. This focused on, as I said, rejection and graft function, as well as infectious outcomes. Patients were defined as obese if their BMI was greater than 35. Adult transplant patients within the time frame on the slide were included, and the researchers utilized standard belatacept dosing with actual body weight. Patients were tapered off of their calcineurin inhibitor over an 8-week time frame, and at the time of Bela conversion, patients were started on prednisone 10 milligrams. When looking at outcomes, there were 38 renal transplant recipients that were included in this study. 25 were not obese and 13 were obese. On average, conversions from tacrolimus to belatacept occurred approximately 48 days post-transplant, and for about 80% of patients, this conversion was due to nephrotoxicity or for nephroprotection. On the left-hand side, you can see a graph highlighting acute rejection rates in obese, non-obese, and all patients. Overall, there was a significantly higher number of patients that significantly higher number of obese patients that developed rejection compared to non-obese patients. And on the right-hand side, you can see that this also translates into a reduced time free from acute rejection after conversion in the obese patient population. So again, highlighting that obese patients had higher rates of rejection and developed rejection earlier than those compared to non-obese patients. When looking at secondary outcomes, specifically infectious, there were no differences in the incidences of CMV or BK viremia seen between the two treatment arms, and there was no difference in patient or graft survival between groups. The authors also included an analysis of the patient's renal function over time of this conversion, looking at eGFR. And what the researchers saw is that at each time point following conversion, there was no significant difference in eGFR between the two arms. Therefore, the researchers concluded that obese renal transplant patients had higher rates of acute rejection following Bela conversion compared to non-obese. There were no differences seen in graft function, however, despite that increased rate of rejection. More studies are needed to determine the pharmacokinetics of belatacept in obese patients, as well as alternative dosing strategies and clinical outcomes. Switching up to our last abstract in the kidney group is looking at use of induction in Hep C viremic donors and Hep C negative recipients. This abstract specifically compared induction with alemtuzumab to anti-thymocyte globulin and its impact on Hep C clearance and transplant outcomes in Hep C positive donors and negative recipient kidney transplant recipients. There was also a single-center retrospective analysis looking at adult transplant patients who received standard standard maintenance immunosuppression, including tacrolimus, mycophenolate, and a 3-day taper. The direct-acting antiviral that was utilized was based on patients' Hep C genotype and payer preference, and the primary outcome was looking at the sustained virologic response at 12 weeks. Starting off looking at the demographics related to development of Hep C, you can see that alemtuzumab and anti-thymocyte globulin patients developed their first detectable Hep C PCR was approximately 3 days post-transplant, and the genotype was identified approximately 20 days post-transplant, with the DAA therapy started approximately 2 months post-transplant in both arms. So no differences in demographics with regards to when Hep C itself was detectable and when therapy was started. Now, focusing in on what therapies were utilized, Mavorite was the DAA of choice or used the most in this study, followed by Epclusa and then Harvoni. When looking at achievement of SVR, at the end of study conclusion, only 15 patients had completed their therapy, but of the 15 patients that did complete, 100% of them, 5 in the alemtuzumab arm and 10 in the anti-thymocyte globulin arm, did achieve SVR12. There was no difference in the rate of biopsy-proven acute rejection between the two groups. The patient who developed AMR in the alemtuzumab arm was highly sensitized prior to transplant, and the DAA therapy was started 2 days prior to rejection, so it was not thought that this therapy contributed to the episode of rejection. Overall, the researchers concluded that alemtuzumab did not impact Hep C clearance or transplant outcomes compared to anti-thymocyte globulin. We are going to switch it up very briefly into the liver transplant abstracts, 2 of which are going to focus or discuss the conversion from calcineurin inhibitors to tacrolimus. The first one to sirolimus, or an mTOR inhibitor, I should say. So the first one is looking at outcomes in liver recipients maintained on tacrolimus compared to those converted to a calcineurin-free regimen, specifically with sirolimus. This was a single-center retrospective study, including adult liver transplant patients. Within the time frame mentioned above, 244 patients underwent conversion from tacrolimus to sirolimus, and then patients in the tacro arm were matched to sirolimus patients based on indication, age, and renal function. The primary endpoint evaluated in this abstract was looking at eGFR at 6 and 12 months after transplant. On average, patients were 61 years of age, and the majority of patients were Caucasian. And on the left-hand side of the slide, you can see eGFR change over time from conversion with tacrolimus in the blue arm and sirolimus in the orange arm. There was a significant difference between the two arms. So tacrolimus patients as a whole had higher eGFR at all time points post-transplant or post-conversion compared to the sirolimus arms. However, there was a larger decline in renal function in the tacro arm compared to the sirolimus arm. Now, when we're talking about a larger decline, it's really only about a 2 ml change. So there was a 5%, or not a 5% change, but a 5% value of 67 to 62 eGFR in the TAC arm and 60 to 57 in the sirolimus arm. So not a very clinically significant difference between the two arms. Then looking at biopsy-proven acute rejection, similar rates of rejection between the tacrolimus and sirolimus arms, and with tolerability as expected, sirolimus had higher levels of total cholesterol, triglycerides, and blood pressure at 12 months. So after reviewing this abstract, the researchers stated that additional studies are needed to determine the potential benefits of this conversion therapy. The second abstract was comparing patients who were on tacrolimus and transitioned to everolimus. Now, the researchers also wanted to look at if there was a difference in the outcomes with regards to timing of this transition. So 4 groups were included in the study. Group 1 was less than 90 days, so conversion from tacro to everolimus occurred less than 3 months post-transplant. Group 2 was 91 to 180 days. Group 3 was 181 to 365 days, and Group 4 was greater than 1 year out. The primary outcome the researchers looked at was renal function at 1 month after transition compared to baseline, and secondary outcomes was looking at the renal function 12 months after transition, as well as rejection rates at that time point. Now, there's several different comparisons within this single chart. The groups are listed on the left-hand side, and first we're going to look at creatinine clearance 1 month post-transition. And what you can see when looking at this is patients who were converted to everolimus in group 1, 2, or 3, which is specifically within a year of transplant, there was a significant improvement in eGFR or creatinine clearance at this time point. However, patients converted more than 1 year following liver transplant did not have a benefit or improvement in their creatinine clearance. Fast forwarding to the middle of the chart here, we're looking at creatinine clearance comparisons 1 year after conversion, and a benefit in creatinine clearance or an improvement in creatinine clearance from baseline was only maintained 12 months after transition in groups 1 and 2, which are patients that received a conversion within the first 6 months of transplant. The other interesting aspect to look at is on the right-hand side here, which is biopsy-proven acute rejection 12 months following transition. And what you can see is the earlier time frame that patients were converted, the higher the rejection rate. So patients converted within 3 months post-transplant had the highest rates of rejection compared to patients converted more than 1 year out. As a result, the researchers concluded that everolimus conversion within the first 6 months showed improvement in eGFR, but early transition did have a risk of higher rates of rejection. And so the best time to transition really may be this group 2/3 timeframe, which is within 6 months of transplant, but less than 1 year. The final abstract I'm going to quickly present was looking at checkpoint inhibitors in liver transplant recipients. This was a case series that was published looking at 5 liver recipients who received nivolumab for HCC prior to transplant. Of the 5 patients, 3 received thymoglobulin for induction, 2 did not, and all received standard immunosuppression with TAC, mycophenolate, and steroids. Looking at this chart, it includes the 5 patients that received checkpoint inhibitors before transplant. And what's important to note is really looking at this time from last checkpoint inhibitor dose. And when you see patients received their checkpoint inhibitor less than 3 months from the time of transplant, so their last dose of it was less than 3 months before transplant, they had patients developed episodes of cellular rejection as well as hepatic necrosis that required therapy with thymoglobulin, steroids, and then either rituximab or plasmapheresis. Patient A, his graft was able to be salvaged with this therapy. However, patient B unfortunately had to undergo transplant. Patients who received their last dose of checkpoint inhibitor more than 3 months from time of transplant did have stable function of their graft post-transplant. Patient E did pass away due to sudden cardiac death at an outside hospital, but it was believed to be unrelated to the checkpoint inhibitor. So in conclusion, the risk of cellular rejection and AMR and immune-mediated hepatic necrosis with the use of checkpoint inhibitors are valid concerns, and a washout period is needed between the last dose of checkpoint inhibitor and transplantation to try and minimize these adverse outcomes. From this case series, 3 months is proposed as a minimum period of washout. However, more centers do need to publish their data if they've used this in their transplant patients to see if there's a more optimal waiting period. And with that, I am going to pass it over to Dr. Heeney to start talking about the cardiothoracic and infectious disease abstracts. Thank you.
Thank you, Amanda. My name is Stephanie Heeney. I'm excited to share with you some of my favorite presentations from ATC this year on heart, lung, and infectious disease. I do not have any sort of financial disclosures or conflicts of interest. And this is going to be our roadmap for the presentation. We are going to go ahead and start with heart transplant. So our first study here looks at ACE inhibitor use after heart transplant. We know that hypertension is a common comorbidity after heart transplant, and I think many of us are continuing to search for the optimal antihypertensive regimen based off of individual patient characteristics. One of the things we know about ACE inhibitors is that it's renal protective in the general population. And so this poster out of Cedars-Sinai explored the possibility that ACE inhibitors may be particularly beneficial in our heart transplant patients that had diabetes pre-transplant. This was a retrospective review of heart transplant recipients from 2010 to 2019, and they compared the serum creatinine of patients that were started on an ACE inhibitor within 3 months of transplant with those who were not. You can see here from our baseline characteristics table that we had 4 groups, those that had diabetes pre-transplant and those that had not, and then they were subdivided into those that were started on ACE inhibitors within 3 months post-transplant and those that were not. I do want to notice some slight differences in our baseline characteristics between groups. Patients with diabetes pre-transplant were more likely to be older, have CAD as their indication for transplant, and have a higher BMI. These differences were likely reflective of the diabetic population at many centers, but there were, regardless, some differences in their baseline characteristics. When we look at their results, the first thing we notice here is that serum creatinine at baseline was no different between groups. This was likely reflective of their inclusion criteria. So they required patients to have what they called normal renal function at the time of transplant, and they defined that as a serum creatinine of less than 1.3. Looking at 1 year post-transplant, patients who were not started on an ACE inhibitor within 3 months and had diabetes pre-transplant had significantly higher serum creatinine at 1 year, and I would say statistically and clinically. There were no differences in freedom from proteinuria, although the authors did not report on mTOR use in this population. Overall, the authors concluded that the addition of an ACE inhibitor to patients with diabetes pre-transplant may be protective against CNI toxicity. It does appear could be some sort of protective effect. Of course, this is a retrospective study. It would be wonderful to see this data published on a larger scale, maybe with tacrolimus levels and mTOR use to help guide our hypertension management post-transplant. Our second study here assessed the impact of statin intensity and transplant outcomes. Statin titration and intensity remains kind of a hot topic in heart transplant, and I would say the optimal dose and timing is not entirely clear. This was an oral presentation out of the University of Maryland. It was a retrospective review of heart transplant recipients from 2012 to 2020, and they compared 47 patients who were started on high-intensity statins to 95 patients that were started on low or moderate intensity statins. Patients had to be started on statin therapy within 6 months of follow-up to be included. Their primary outcome was a composite outcome, and it included CAV, PCI, graft loss, and death, and they also assessed change in lipids and adverse events rates. It is important to note that with the retrospective nature of this study, statin intensity was, of course, based off of patient history and provider preference. So we kind of have a lot going on here. Patients were approximately 58 years old. They were majority male, and interestingly, the majority of them were non-ischemic. There was no significant difference in comorbidities, and notably, aspirin and sirolimus use was fairly similar between groups. There was, however, a higher rate of patients receiving thymoglobulin induction therapy in the high-intensity group. This does make me wonder if there was some sort of baseline difference between these patients and their predicted rejection risk, or perhaps there was a change in practice over time that was reflected in choice of induction. But regardless, to me, this is a signal that the groups are a little bit different, although that's not captured in any of their other baseline characteristics. Here we have their Kaplan-Meier curve depicting their primary outcome, which was freedom from this composite outcome. When they adjusted for covariates listed on the bottom right-hand corner, there was no difference between groups. Looking at the two lines, there doesn't even appear to be a signal or a trend that the outcome was improved with high-intensity statins. But again, patients were identified and selected based off of patient history, and I do wonder if this could have impacted their results. Additionally, there were some differences in induction, and so it does make me wonder how different these groups are. Interestingly, there was no statistically significant difference in change in metabolic parameters looking at lipids and A1C over 12 months. The authors also found no difference in adverse event rates, and they reported no instances of rhabdo. So overall, the authors conclude that early initiation of high-intensity statins was not associated with an improvement in clinical outcomes, and that high-intensity statins should be reserved for managing hyperlipidemia post-transplant. I will admit my personal bias here. I have always wondered if high-intensity statins, through their alternative mechanisms, would lead to some sort of benefit after transplant. But I think it's important that we make sure we are publishing and seeing negative studies as well. So while this study didn't find a difference in adverse event rates, we know there's a higher risk in the general population with high-intensity statins. And I think we need to acknowledge that we're subjecting our patients to that risk when we haven't really identified a clear benefit in escalating doses. Our last study that I'm going to talk about in heart transplant reviewed steroid-free immunosuppression in our heart kidney transplants. So this is, I would say, it's currently common practice to maintain heart kidney transplants on prednisone maintenance immunosuppression for life, but this is a relatively controversial standard. So the group at Cedars-Sinai retrospectively reviewed their dual heart kidney transplant patients and compared the outcomes of those that were eventually weaned off prednisone versus those who were maintained on prednisone. All of the outcomes they assessed were 1 year subsequent prednisone discontinuation, and the average time to prednisone discontinuation was 336 days, so on average just under a year. This group found no difference in any clinical endpoints, including freedom from CAV, acute cellular rejection, antibody-mediated rejection, and kidney rejection, although the rates of CAV and rejection are fairly low in this study. They also assessed changes in renal function at the start and end of their wean, but found no clinical or statistical difference between the groups. So looking at this study, we don't have a lot of information on baseline characteristics, and induction choice might have played a role in our ability to wean prednisone off, especially in those that we weaned earlier on. But I do think this study is interesting food for thought. Every now and then we have a patient that would like to get off prednisone. Maybe they have metabolic disease and don't have a history of rejection. And this study may indicate that select heart kidney patients may not need to be subjected to lifelong prednisone. All right, moving along to lung transplant. Recently, we've actually seen quite a few papers and abstracts on Apixaban use in lung transplant, which has been exciting, but it continues to be a controversial practice, at least at my center, particularly because of the drug interactions that need to be managed in this patient population. So I'm excited to see the experiences of other centers continue to make it to meetings and journals. This poster presentation was actually just published this July in Clinical Transplantation, so congratulations to the authors. The group at Baylor performed a retrospective review of 28 lung transplant recipients who received Apixaban for either VTE treatment or prophylaxis for atrial fibrillation. And something to note is that their adjusted creatinine clearance was 82 mils per minute baseline on average. So on average, these patients had relatively normal renal function. As a pharmacist, I appreciated the drug interaction table they included. Something to note here is that 46% of their patients had no drug interactions, and only 4 patients were on strong 3A4 inhibitors. The authors also stated that 4 patients, so 14%, were started on reduced dose Apixaban for drug interactions or clinical judgment, but we don't have any details on the magnitude of drug interaction or how they decided who to dose reduce. Their primary outcome was a composite outcome, which is essentially summarized in this table in front of you, and included major bleeding, clinically relevant non-major bleeding, breakthrough VTE, and stroke. Their primary outcome occurred in 2 patients. One patient had a clinically relevant non-major bleed, which was a GI bleed that was secondary to a gastric ulcer. And it's important to note that in this patient, there were no drug interactions with Apixaban. Another patient developed breakthrough lower extremity DVT while on Apixaban. So overall, the authors conclude that Apixaban appears safe and effective in lung transplant recipients. I would agree with that, especially in patients that were not on azole therapy or did not have drug interactions to worry about. So I can say at our center, the majority of time when we're starting anticoagulation for VTE or AFib, our patients are usually early post-transplant, and almost all of them are maintained on azole antifungals. So their population is slightly different from ours, but it is still helpful to see good clinical outcomes and suggests that Apixaban can be safely used in patients without significant drug-drug interactions. So because our center tends to steer clear of DOACs until patients are off their azole antifungals, we utilize quite a bit of enoxaparin for therapeutic anticoagulation. So this year we performed a retrospective review of lung transplant recipients from 2017 to 2020 who received enoxaparin for therapeutic anticoagulation. Now, all of these patients received 0.8 mg per kg, Q12. This is per institutional protocol and based off of previous literature. Patients were excluded if they had a creatinine clearance less than 30. They wouldn't have received enoxaparin anyway based on our protocol. And so we included a total of 29 patients. There was a subset of 12 patients with a creatinine clearance between 30 and 60 milliliters per minute that we classified as having renal dysfunction. The majority of our patients received anticoagulation for VTE, although a small number of patients did receive atrial fibrillation prophylaxis, and the majority of patients were within their first 60 days post-transplant. The bar graph on the left depicts the incidence of therapeutic anti-10A levels, which we defined as 0.6 to 1. The light bars indicate patients with moderate renal dysfunction, and the dark gold indicate those with a creatinine clearance greater than 60. As you can see here, the supratherapeutic anti-10A levels occurred more frequently in the subset of patients with a creatinine clearance of 30 to 60. Looking at the table on the right, we see that while the mean enoxaparin dose was no different between groups, the mean anti-10A was statistically significantly higher in the patients with moderate renal dysfunction. We also assessed clinical outcomes, including bleeding and thrombotic events. We had 2 patients with clinically relevant non-major bleeds and 1 major bleed. And all of these bleeding events occurred in patients with a moderate degree of renal dysfunction. All of these patients had a supratherapeutic anti-10A level initially. So we have made some changes in our institutional protocol based off of these outcomes, and we now empirically reduce the initial enoxaparin dose in patients with renal dysfunction and are thoughtful about therapeutic anticoagulation in patients with atrial fibrillation right after transplant. All right, our last lung transplant submission we're going to discuss is out of the University of Chicago on the use of elexacaftor, ivacaftor, tezacaftor in lung transplant recipients. As many of us are aware, this drug was approved in 2019 and has been a game changer for the cystic fibrosis population. So the purpose of this case series was to explore the benefit of non-pulmonary manifestations of this drug. So all patients had the F508 delta mutation and had extrapulmonary manifestations of their cystic fibrosis. 7 patients were included in total, and they were on therapy for an average of 324 days. 4 of those 7 patients had an improvement in CF-related pancreatic insufficiency, ranging from reduced pancreatic enzyme doses to more regular formed stool. 4 of the 7 patients had CF-related diabetes at baseline, and 2 of the 4 had an improvement in diabetes control that was reflected in an improved A1C after 1 year. 1 patient reported improved control, but that was not reflected in their A1C. And then all 7 patients had sinusitis, and 4 of the 7 reported benefit in therapy. So overall, it appeared that some patients were reporting benefit with this medication. So kind of leaves the question, are there any adverse events or patient harm occurring when we're starting all of these drugs with the many medications our lung transplant patients are taking? So I apologize, this figure is a little bit blurry. I'm going to walk you through it. The x-axis is months since drug initiation, and the y-axis is white blood cell count. 2 of the 7 patients, and that would be the patient indicated by the yellow line and the navy blue line, had a fairly clear reduction in white blood cell count after starting therapy. The patient that was represented by the yellow line responded to dose reductions of other medications. However, the patient represented by the navy blue line did require cessation of drug therapy. Most patients had no hepatic side effects. However, one patient clearly had a rise in ALT after several months of drug therapy. What's interesting is the authors describe this normalizing after the drug was discontinued, but it didn't recur when the patient was re-challenged with the drug. So they found it unclear if this was related to drug therapy. And of course, since I'm talking to a bunch of pharmacists, it's important to mention that the therapy had a noticeable impact on tacrolimus dose requirements. So most patients required a dose reduction in order to stay within goal range of about 20%. However, we didn't have any sort of concentration over dose analysis to refer to. Overall, the authors conclude that elexacaftor, ivacaftor, tazecaftor may provide extrapulmonary benefit in post-lung transplant. However, tacrolimus monitoring should take place with drug initiation. Moving along to infectious disease, I pulled out a couple of projects on Pjp prophylaxis. This rapid-fire oral abstract is out of the University of Michigan, and it reported their experience using reduced-dose Pjp prophylaxis in lung transplant recipients. At their center, they used sulfamethoxazole trimethoprim single-strength Monday, Wednesday, Friday, and dapsone 100 milligrams 3 times a week for Pjp prophylaxis, which is continued lifelong. This was a retrospective chart review of the incidence of lung transplant recipients with Pjp. At their center, 11 patients developed Pjp from 2007. 7 of those patients were not maintained on prophylaxis at the time. 4 were maintained on prophylaxis, and those are the top 4 on the screen. And as you can see, 3 of the 4 of those patients were cystic fibrosis patients. 2 of the patients were on reduced frequency dapsone, and 2 of the patients were on reduced dose sulfamethoxazole trimethoprim. None of them received induction therapy, and they all appear to be on relatively standard immunosuppression regimens. The authors noted that the majority of patients with Pjp infection had previous rejection treatment, so the red boxes on the screen, and or CMV infection, the orange boxes, and both of those are known risk factors for developing Pjp. They do comment on why Pjp was held in some of their patients. So in 6 of the 7 patients, it was held for leukopenia, anemia, AKI, or hyperkalemia, and they had 1 patient that had mistakenly stopped taking prophylaxis. Overall, the authors conclude that the incidence of Pjp prophylaxis in their cohort while on prophylaxis was low. It was about 1%, and felt that the reduced dose regimen appeared to be effective for prevention. However, they call into question the appropriateness of using this reduced dose in our cystic fibrosis patients. Our center has never utilized reduced dose dapsone therapy as a prophylaxis strategy. So this is one that I'm going to tuck away. I don't know that I would consider it in a I would consider it in a cystic fibrosis patient, but in a non-CF patient that wasn't tolerating their usual regimen, but was at high risk for opportunistic infections, it could be considered. And our last infectious disease abstract is out of New York Presbyterian, and it was actually recently published as a short communication in transplant infectious disease. This was a retrospective review of renal transplant patients who received either dapsone or atovaquone after discontinuing sulfamethoxazole trimethoprim. The majority of patients were transitioned off for hyperkalemia, cytopenias, or rash. Their primary endpoint was a change in hemoglobin within 90 days of drug initiation. 100 patients were included, 50 that were transitioned to dapsone and 50 that were transitioned to atovaquone. And all of our dapsone patients had a normal G6PD. There was no difference in baseline hemoglobin between groups, but clearly the median nadir of hemoglobin was significantly lower in our dapsone group compared to atovaquone. What's interesting is dapsone was discontinued in 46% of patients, whereas atovaquone was discontinued in 18%. And I think we see this sometimes anecdotally, but it's good to see it in the literature. All patients in the dapsone cohort were discontinued either due to clinically relevant reductions in hemoglobin or methemoglobinemia. So I do wonder with the large percentage of patients that were pulled off of dapsone if that explains kind of this bump in hemoglobin that we see at 30 days. The authors concluded that in renal transplant recipients with a normal G6PD, dapsone was associated with greater hemoglobin reductions and rates of drug discontinuation compared to atovaquone. So again, I think many of us see this anecdotally. I personally try to avoid switching someone from Bactrim to dapsone for anemia, but it's helpful to have this data, at least in renal transplant, to back this up. Atovaquone certainly isn't a hit with patients, but in a patient who isn't anemic at baseline, it may be the better option. And then I could not help myself. I had to throw this in here as a huge shout out to some of the pharmacists that are publishing their work this year. So Henry Ford submitted a review of their vaccination rates in liver transplant patients, and they implemented a pharmacist-driven immunization clinic and assessed patients' need for vaccination pre-transplant. And not surprisingly, they showed a significantly greater rate of patients who started vaccination prior to transplant were vaccinated against hepatitis B and the pneumococcal vaccine. At Mass Gen, like many places across the country, COVID-19 created big challenges for them seeing their lung transplant patients in clinic. And so they started conducting telehealth visits prior to provider visits and documenting their notes in the chart. They saw 385 patients via virtual visits from March to September of last year and documented 864 interventions. So that's a lot of interventions that wouldn't have been made if they didn't change up their model and embrace telemedicine, as many of us have across the country. I think it's important to consider other models, and I loved their model of timing the visit right before the provider visit. And then at UNC, they added an ambulatory care or ambulatory heart transplant pharmacist to their team in 2017. They retrospectively assessed the change in patient outcomes before and after the addition of this pharmacist and found that patients were more likely to be at goal blood pressure, be maintained on a statin, and they also documented fewer hospital readmissions, which is really neat. So thank you so much. Proving the worth of a pharmacist is challenging, and I think most centers were still working to identify meaningful outcomes to track. So huge thank you to the pharmacists that are working on publishing data on pharmacist work. And that completes my ATC recap. Thank you again to the IMTR PRN for having me, and I'm happy to answer any questions.
Thank you both, Amanda and Stephanie. So we do have a couple of questions in the chat. I'm not sure if you can see them, but I'll go ahead and read the first one. I believe this one is for Amanda. For the MMF weight-based abstract, how many patients in the less than 80 kilogram group were below 50 kilos and received a lower dose of MMF? And how long were patients on the lower dose based on weight before it was dose titrated up during the first year?
Yeah, those are really great questions. So specifically, there were 30 patients that were in the weight-based dose that weighed less than 80 kilos. The authors presented a bar graph that highlighted the MMF dose 12 months post-transplant. So there was no information provided as to time to dose change, whether it was an increase, like time to increase in MMF dose post-transplant. It was just a single snapshot of time, and it showed, I should say it was approximately, the mean MMF dose was about 1,200 milligrams in all groups post-transplant 1 year. So unfortunately, we don't know how long patients were on the lower dose before they were up titrated within the first year. And then it was 30 patients that received a lower dose of MMF to start.
Yeah, that was a really interesting study. I have more questions if we don't get more in the chat about that one, but we do have another question about, I believe this is the liver transplant and everolimus study with, what everolimus trough goals did the researchers target in those patients transitioned from tacrolimus to everolimus after liver transplant? And were these patients also maintained on MMF and or prednisone, or was this a monotherapy regimen?
Yeah, and those are also great questions. So I'm going to answer the second question first. And the authors had stated that combination with immunosuppression, so other immunosuppression, meaning MMF or prednisone, versus monotherapy was according to physician discretion. So there was no data provided on what % of patients were maintained on MMF and or pred versus monotherapy. This was an abstract, so there was no poster or audio recording with it. So it's just what was included in the abstract. And along those lines, the everolimus trough goals were also not included in the abstract. So I don't know what their goal, standard of care with everolimus levels are, as well as I'm unsure or unclear of what goals patients actually attained in the study was not included.
And Stephanie, I have a question for you. So when you were kind of perusing through the pharmacy studies and impacts and whatnot, what advice would you give to folks on the phone about, you know, since you have a abstract in there, or your center does, what's kind of some advice to make sure that we're getting what pharmacists are doing out there?
Oh gosh, I think we're all kind of in this point in time where we're trying to figure out what outcomes are most meaningful, not just to us as pharmacists, but also to administration for justifying positions and things of that nature. And so I think anytime we can go back and look at clinical outcomes, those are definitely the gold. So if anybody has a change in practice, new pharmacist in clinic, or adding someone in, or changing their model, taking a look at clinical outcomes and seeing if that may have made a difference is always going to be ideal and a huge help to all of the pharmacists out there that are trying to get more positions approved.
I think that is great advice. So definitely everybody will take it to heart. What a wonderful review from both of you today. I really appreciate you all presenting, and thank you to all of the attendees. And with that, we will wrap up this 7th webinar of 2021, and great to see and hear from everybody virtually.
Thank you.